This is not a Buffalo concussion test for initial evaluation. This is for clearance. It serves a completely different clinical purpose that we need to be using this to inform our return to play process to make sure that these athletes are safe.
Welcome to APTA Orthopedics podcasts, where we help you stay ahead in orthopedic physical therapy. I'm your host, Megan Hamoki, and today I'll be talking with Victoria Kocik about return to sport testing post-concussion. Don't forget to subscribe for future episodes. Let's get started. So Victoria, I'm super excited to have you with us today for so many reasons, but let's just start with having you share a little bit about yourself with our listeners.
Sure. Yeah. So I, upon graduating from PT school, I did UPMC's neurologic residency. And at the time when I went through the residency program, they had two tracks. They had a concussion track and they had a traditional neurologic track. And I opted to do the concussion track through the residency. We still rotated through inpatient units, but a majority of the second half of the clinical was in the outpatient sports med facilities at UPMC. After I completed my residency, I worked in outpatient the neurovestibular program for UPMC. And I had done that for a couple of years, but I just kept feeling pulled towards concussion management. And about 5 years into practicing, a position became available that was called the Exertion Therapy Coordinator. And through that Exertion Coordinator role, what I did is sort of worked as the complement to the vestibular therapy coordinator. And we worked to collaborate on research projects and then also establish norms and clinical protocols for the UPMC concussion program, including things like exertion testing and exit testing and return to play clearance. Shortly after I started in the exertion coordinator role, we had done a lot of traveling, a lot of lecturing, a lot of additional training. And I felt like we really needed to standardize and publish our return to play clearance test because it was a lot of what I was talking about. And eventually we have published that test. It's one of I think the reasons that you invited me to come to this podcast and talk today.
Right.
And I wanted to make the next step in validating that test and dedicate some additional time to that test validation. So more recently, I transitioned into an academic role at Slippery Rock University because I want to focus a little bit more time and on exit validation. And of course, I enjoy teaching. I enjoy lecturing. So I'm pretty passionate about that. So I wanted to help to train future clinicians as well. So that's a little bit about my background. A majority of my career has been in concussion or in the very least outpatient neurologic vestibular management.
Mm-hmm. Okay. So I feel like exertion therapy is kind of like this untouched art in the world of concussion rehab, in some centers or in some systems, there's very sporadic or random or non-evidence-based like return to sport testing and exertion therapy, what you're calling it, that isn't necessarily validated or not systematic. And so like I know, for example, when I started treating this population, I really struggled with closing the gap between like asymptomatic patients at rest. They passed their Buffalo concussion treadmill test, cervical and vestibular oculomotor stuff was fine. But then I wanted to get them to return to more demanding and more dynamic activities. And I didn't really have any specific testing for that. And then I started using the exit test because I found out about it from one of the UPMC fellows. So just for the listeners who don't know what the exit test is, can you tell us a little bit about what it entails?
Yeah, sure. And I'll rewind a little bit just to like further define. So exertion therapy, I feel like is a visit type that only exists in our system to just kind of like separate some of the scheduling purposes. Mm-hmm. It just is exactly what you said. It's just that to bridge that gap between those patients that really don't have traditional vestibular impairment. Their vestibular impairment is really high level, maybe some really high level visual motion or maybe like some sensitivity to like multi-plane movements that you really can only capture through dynamic movement.
Right.
And it's kind of like this gap in our field where maybe we practice in silos. It's like, oh, they have neck pain. Let me send to my ortho friends. Oh, they're dizzy and they're dizzy with position changes. I got to send this to my vestibular pal, right? And concussion is this world where like we have to wear many hats. And exertion lives right in the middle. If you just treat the cardiovascular components with a patient with some exercise sensitivities post concussion, you're going to miss that dynamic piece. And if you just manage it through gaze stabilization and dual tasking exercises and visual motion training, you're going to miss like some of the aerobic piece, or you're going to miss how the neck is impacting some of that if you just stay in this neurovestibular world. So you have to think in that like middle ground, that gray area. And that's really where that exertion like diagnostic category comes into play, but it's not a dedicated visit type. It can be done by like orthopedic therapists, a neurologic therapist, and oftentimes what it is it's a progression of they're starting to become less sensitive from a vestibular perspective. So I start exercising them, right? So that's the sort of exertion therapy category. But it's an advanced vestibular therapy. It's just that return to play process and a way to categorize it outside of like a staged return to play model, because I feel it's that cookie cutter approach. It's that really protocol strict approach that just, it doesn't work for everybody. There's no one way to return an athlete to play. You need to manage their like different profiles and what they're bringing to the table. So these very like strict 5-stage protocols, it's just not it. So kind of categorizing it instead of a 5-stage protocol, we kind of categorize it as this exertion therapy is what we call it, instead of that 5-stage process. However, at the end of that 5-stage process, so we've done our autonomic testing, we've done our Buffalo concussion treadmill testing, we've done our VOMs, we've done all of those other standardized measures, and they're starting to look very close to normal. They're starting to look asymptomatic. They're not having any symptoms at rest. They're back in school. Maybe they're back in non-contact practice and they're doing really, really well. At that point, in a traditional rehab setting, a lot of times they go back, and if their VOMS is 0, their PCSS or whatever symptom score you're using is 0, and their neurocognitive assessments are normal, what other standardized measures do you have to determine that an athlete's going to be safe for return to play? And a large gap is, well, can they exert at 80% of their heart rate max? Can they participate at a game intensity and also remain asymptomatic?
Right.
So we've always, in my time at UPMC, we've always had a clearance exercise test that we've utilized. However, it wasn't published and it wasn't terribly standardized enough to study to publish. And so that's where I really wanted to make sure that we dedicated some time. And I wanted to make sure that we worked to create a test that is standardized so it can be used with any athlete. We can validate it and kind of captures that last piece. So sure, they've made it through their 5 stages. Sure, they can participate in non-contact practice, but can they participate at that game intensity and not have any vestibular dynamic sensitivities and not have any autonomic nervous system dysregulation? And honestly, sometimes these athletes that have been out for a while, are they even conditioned enough to return to play?
Yeah.
Because that's where I feel like these orthopedic injuries come into play with
Yes.
like this return to play process. If they've been out for 3 months or 6 months, and just because they're asymptomatic, are they even fit enough to return to a college soccer field or football field or a hockey arena? They
Right.
might not be. And this is a test that can, maybe it doesn't prevent them from returning to play from a concussion perspective, but it's something to inform the coach of, inform the athletic trainer of, hey, this individual, they're likely good to go from a concussion perspective. They had a normal exertion test, which is what the exit test is. Everything has tested normal, but they're really out of shape. They were really winded. They were really sore. They required longer rest breaks. Those are also things that we're picking up on the exit test that are like concussion plus. So the exertion test is truly just that last sort of checkpoint to make sure that they can safely return to play. yes, the goal is always making sure that you want to maintain brain health and that they're clear from a concussion perspective. But a surprise of this more intense exertion test is also if they're maybe not fit enough or they're just deconditioned. And that's not necessarily our choice, is the um, exertion therapist or the vestibular therapist, unless we are the team PT. It's oftentimes the team's decision on whether they want to return them to play or maybe hold them for another week and just work on like regular old strength and conditioning to maybe
Right.
additional injury.
I'm glad you mentioned that because there's actually some, I'm sure you're aware of this, but there's some interesting literature about like increased risk of musculoskeletal injury after concussion. And
Mhm.
I think people definitely neglect that piece. And concussion in and of itself is already such a complex injury because it can be orthopedic, it can be neurological and vestibular and exertion and all of those different things working together. But then when you throw that into the mix, it can be a serious problem in terms of fully returning to play. And we kind of already struggle with return to play for many diagnoses, right? Like there's a robust amount of literature out there on like return to play after ACL reconstruction or like prevention of ACL injury initially, and yet those injuries still happen. So we're just dealing with that in an even more complicated sense with concussion, I feel like.
Mhm.
Okay, so let's talk about actually what you do on the exit test. Like, what, give the listeners like a sort of example as to what types of tasks we're expecting someone to be able to do. And maybe if you know, like, how those tasks were chosen.
Yeah, absolutely. So the exit test is kind of divided into two components. One's a cardiovascular component because we know autonomic dysfunction is relevant and we want to make sure that that doesn't present itself the first time that they're back on the field and ready to play. And then the dynamic component. So, a lot of the exercise related assessments that have been established for concussion focus on that cardiovascular piece. And it is so important. So, Buffalo concussion, everybody is using that, but that is just cardiovascular. And there's even options to make it less vestibular. If you
Right.
don't want to have them up on their feet, we can do it on the bike to take the vestibular system even further out of the equation. So the second piece of it is that dynamic piece. And through the dynamic piece, we have the athlete progressively moving through not only more complex physical movements, but then it ends with some dual task, go, no go type of paradigms as well. So the exit test starts with 12 minutes of cardiovascular activity. And the 12 minutes of cardiovascular activity in the originally published exit article that was published in 22 is on the treadmill. So it starts with a 2-minute warm up at a low intensity pace. And I will circle back to talk about what we defined low intensity as. And then after the 2-minute warm up at a low intensity, it moves into 30-second intervals of high and low intensities. So 30 seconds at a high intensity, 30 seconds at a low intensity, alternating, almost like some high intensity interval training. So there's 10 minutes of those 30 seconds on and off at high and low intensities after the 2 minutes. So that's how you get to the 12 minutes total on the treadmill. And we established those treadmill speeds using the ACSM guidelines. So the high and low intensities were derived from the VO2 maxes listed in the ACSM most recently published at the time ACSM guidelines. And there's actually a conversion. So there's an equation to convert the VO2s to treadmill speeds. So we chose a superior athlete 60 to 90, 60% and then 90% of their VO2 max. So 60% is the low speeds on the treadmill, and the 90% is the high speeds on the treadmill for that superior category of an athlete. So, in true ACSM fashion, we have different treadmill speeds for females versus males. So, for females, it converted to 7.2 kilometers per hour, which is about 4.5 miles per hour on the treadmill for that low intensity, that 60% of their VO2 max. And then the high intensity was 11.27 kilometers per hour or 7 miles per hour on the treadmill. So not terribly fast running speeds on the treadmill. However, we wanted them to get to that 90% of their VO2 on the treadmill. So we didn't make up those treadmill numbers and kind of guess at what would be 60 or 90. And exit, which I don't know if you're going to ask about, but exit's only really validated for high school, college, and professional athletes anyways, which is why we chose that superior category, because that's the level of athlete that we were looking to address, really that safety with return to play. Not that other types of athletes don't matter, but that really is that highest risk, highest stakes athlete category are those that they're on scholarship. It's the most important game. They might be underreporting, and we really want to make sure they're safe for return to play. And then the males, it was 8.85 kilometers per hour or 5.5 miles per hour on the treadmill is that low intensity. So that warm up speed and that recovery speed during the 30-second intervals, and then 13.6 kilometers per hour for the high intensity or 8.5 miles per hour on the treadmill. So that's how we established the treadmill speeds. We wanted the whole entire assessment to take about half an hour or less, which is why we kept the treadmill duration short-ish. But that 10 minutes of those intervals is
not easy.
Pretty intense. Yeah, not easy at all. We've since converted those treadmill speeds to a pacer. I don't know if you've ever done like a beep test where you're running between cones at different beep paces. We have an audio file and we have data from a pacer study that we're actually submitting for publication now. Nice. So that if you don't have access to a treadmill, you can still do the exit test, because that is a barrier, is not having one. And we honestly didn't realize how many high schools didn't have access to treadmills until we started to implement this particular exit into like across the UPMC system, and realized that it really is a significant barrier, whether the high school has it or not, or it just might not be available. They're out on a field and they don't have time to go back into the gym to do the cardiovascular component. So keep your eyes out for the pacer model, which is truly just an audio file. And it's just a consistent beep test with directions as you go. It's pretty easy. It's pretty user-friendly. And that is one of the next directions for exit, to make it more clinically feasible. Not only is it short duration, but we wanted it to require as little equipment as possible.
Right, yeah. So, okay, here's my question. If you run them through this portion, like the interval training, and the individual becomes like, what's the cutoff for too symptomatic where you're like, okay, I'm not even going to finish doing the test?
Yeah. So that's a great question. And we get that a lot. So I have two different answers for that piece of things. Technically, it is a failed test if they get any symptoms, right? So we're also counting errors, but we don't know how many errors is problematic. That's one of, again, the next steps that we're making is how many errors is too many errors that it's a failure. We don't know that yet. We do know what we count as an error. But if they get any symptom increase, then it's a failed assessment. So technically, if they get any symptom increase, you can discontinue the assessment because it's a fail no matter what.
Right. Okay. Because I feel like with the treadmill test, it's like if you increase symptoms 2 points or less, it's still considered a pass.
Right. Nope. We want like no changes, and we want them to stay baseline. We don't want them symptomatic with exercise.
Okay. Yeah.
But clinically, so the other answer to that question is clinically, I leave it up to the athlete. So I might let them finish the treadmill protocol and say, hey, listen, are you typically getting headaches or dizziness or nausea, whichever one of the symptoms presents? No, I'm not. This is a little bit abnormal. Like we have a little bit of a discussion about it. I ask them if they want to continue to kind of get a preview of like what they're going to have to pass to return to play. And honestly, a lot of them do choose to continue.
Yeah,
and we just aren't as rigid about the rest breaks, because typically I am very rigid about how long they wait between, but we take a more casual pace through the rest of it and we treat it as like a treatment session. So I do continue exit even if I know that they're not passing, Or sometimes it's not clear, right? We have these really sensitive athletes at baseline, these headachy teenagers, or somebody that maybe does get nauseous whenever they get into 90% of their VO2 max. And we're not quite sure, are they just really out of shape that they got nauseous?
Yes, I've had
Or
that.
is this a true concussion abnormality? If we're also not sure, I sometimes continue because symptoms have been a reason that I've told the referring clinician, like, listen, I think this is a passing test here because here are the symptoms that they got. I think they're just out of shape. I think they're just deconditioned. And that's why they got a little headache or that's why they got a little bit nauseous. I have to report that it's an abnormal test because they got symptoms. But in our clinical discussion, we talk about, like, I think it's a deconditioning manifestation. So if you're not sure, continue the test. And if you are pretty sure that it's some type of exertion intolerance type of situation, then I do give them the option to continue and not. And a lot of my competitive athletes are like, yeah, let me see it. I'll just take some more rest breaks.
Right. Okay. So then talk me through the dynamic component and what exactly they have to do for that.
Yeah. So coming off of the treadmill, they have about a minute to then start, which it takes you about a minute to then explain. They move into a dynamic circuit with squat jumps, push ups, and ball rotations. And on the like initial study with the circuit, we talk about the pacing of it being 25 beats per minute because honestly, we let VOMs 50 beats per minute with cancellation kind of dictate that speed. So the ball rotations are at the same pace as the VOMs cancellation because they have to go down and back between each beat. I do not play a metronome for every single patient, but as you're getting familiar with the exit test, I encourage you to use it for your first couple of patients because it's slower than the athlete's going to want to move, but we don't want them to burn out coming off of the cardiovascular activity, moving into a dynamic circuit because they still have a lot more activities to do. So it's almost like a check for the athletes that they don't have to continue to move at that 8.5 miles per hour pace because they've just come off of basically a sprint. So they're amped up and they're going to want to do squat jumps really, really intensely. So just get a gauge of it to be like, slow down a little bit, slow down. It'll be okay. Let's just move at a slow, continuous pace. So yeah, squat jumps, push-ups where they're moving side to side, almost like a clock push-up with just a slight lateral component. And then the med ball rotations, of course, for that visual motion piece of things is the circuit. They go through the circuit 3 times. They get a 30-second rest break between each of the circuits. So it's almost like this 2-to-1 work to rest ratio is what we were looking for. It takes them about a minute to get through all of those, and then they get a 30-second rest break. So that goes for 3 rounds. Then you move into a ball toss. The ball toss, their back is to the clinician, and you just call right or left, and they do a jump turn, 180-degree jump turn. You toss them the ball, they toss it back, they turn back around, and you call again. This is multi-purpose. A lot of patients get dizzy on this one because it's rotational, it's vestibular, but it's the first time you get a glimpse into the patient's cognition, right? So are they able to multitask? Are they able to follow your directions? Because sometimes if they're feeling a little dizzy, they're underreporting, they're going to make mistakes. You're going to count errors. And if they make one step in the wrong direction, it counts as an error. So that's the next one. And then they move into some box drills with some side shuffling, some karaoke. They move into a zigzag drill with 6 different cones where they're side shuffling between the cones, moving forward and then backwards, back. That one's punchy. It can take about 35-40 seconds for them to get through. They have to do 2 laps before they can rest. So at that stage of the assessment, it being a 45-second, more cardiovascular and dynamic. They're bending over to touch cones. They're moving their head to look for the cones. They're moving backwards for more visual input. That's one of the more commonly symptomatic assessments. If they don't get symptomatic with the initial intensity of the cardiovascular activity, and then the circuit drills where we're now making them exert with both their upper extremities and their lower extremities with a little visual motion, they tend to do okay with the circuits until they get to the zigzag drill. So, and then after the zigzag drill, they basically do a shuttle run. They start in the middle, pro agility, they go to each side, touching the cones. Again, quick, dynamic, and it basically sets as a primer because the last 2 are our aero agility drills, which there's a familiarization task with some boxes. And there's then the aero agility piece. There's 16 familiarization cards and there's 16 aero agility cards. And these I just have printed on cardstock paper and I just flash them to the patient. Those ones also take about 40 seconds. And not only are they running from side to side between cones based on the arrow or the box, they're also, after they're done with the familiarization task, the arrows can be a little bit tricky. So it ends up being like a go, no go distraction type of task. So again, that cognitive piece, bringing that in at the very end. And then that concludes the assessment. Throughout the assessment, we're monitoring their RPE and we're monitoring their heart rate and their symptoms. And as I mentioned at the beginning, we're counting errors. With each of these components, it's well defined what counts as an error. And then through all of the dynamic components, we're timing each individual task. It's kind of like a catch-all for effort because we have these patients that maybe are motivated to return to play. It's a scholarship, it's a financial opportunity. They're maybe on the cusp of being cut from a team or something like that, that they're very motivated to return to play regardless of their future brain health. And so they might underperform. So we just want to make sure that they're at an appropriate speed. And again, that's one of the things that we're looking for with further validation, to have those speed cutoffs as to what's normal. So that's what we're monitoring. And oftentimes, when an individual is not passing exit on the cardiovascular piece, their vital signs match that. They have an abnormal heart rate response to activity. So that's where it's just like, okay, I know this dizziness is not just from they're out of shape. I know that this is from an actual autonomic problem.
Right. The one thing that I really like about the dynamic component specifically in terms of utility of the test is that a lot of the time, whatever makes the patient symptomatic, I'll use that to kind of inspire what they need to work on, like what their HEP is, like if
Mhm.
squat jumps are a problem, I have them doing squat jumps, like specific parameters on their own, and then I'll loop that in with something else that stimulates vestibular system a little bit, or maybe doesn't, depending on what level of irritability they have. But
Yeah.
that's what makes this so useful because it's not just a test, it can turn into treatment too.
Right. And that's I mean, of course, you only need space and cones for this. So from a clinical utility perspective, it's easy to reproduce. But the other thing is it's very functional for an athlete. They're used to these cone drills. They've done a pro agility drill before. They've done push up. They've done squat jumps. They feel like very normal strength and conditioning types of activities for the athlete. And that's really, we wanted to use that it wasn't like they're learning a new movement while they're trying to get cleared from a
Yeah, because then
concussion.
that complicates things for sure.
Mhm.
Okay, so you've alluded to this a bit, but where exactly is your team now in terms of validating the test?
Yeah, so we have validated the assessment. We've looked, and so the initial validation was published. We are looking to further validate it with more robust numbers, with more robust volumes, especially with matched, like concussed and controlled athletes. So that's what we're looking to do. We have um, like a multi-site study that we're looking to start this fall on like the concussed athletes, and then collecting controls that are age and sport and gender matched. So we're looking to move forward with that just so we have some more robust data to validate it. We are looking to publish the validation on that beep test component so that you no longer need a treadmill for completion of the exit test. And then through that more robust data, we're looking to like better establish what those error and time cutoffs are, because one thing we want to move away from is just relying on symptoms for all concussion clearance. So we have vital sign measures, blood pressure, heart rate. Whenever we did the initial validation study, we had a 3-lead EKG on each of them to really like monitor their cardiovascular system and autonomic function. So we're looking to just like collect more robust data on that, just to make sure that we are not just relying on symptoms. We're actually relying on vital signs. We're actually relying on some other physiologic measures and some performance-based outcomes on exit. And then the last thing that we are looking to do that's related, but a little bit unrelated, is valid potential modifications of this test if you have an individual that maybe isn't fit enough to perform it as it has been established. So one of the things that we're looking into and considering is a BMI sort of control to capture those really large American football players that
Right.
might not be able to hit 8.5 on a treadmill, right? Right? That's fast. I don't know that that's an expectation for their sport, is that they can run that fast, you know? So, what are some ways that we don't have an exit test per sport? Because that would be an impossible thing, would be to have a different exit test per sport, but maybe have some different ways to modify in a standardized fashion that kind of like captures some of these outliers, or what to do if you have a middle school athlete that's looking to play, or what do you do with, like, I don't know, myself, if I wanted to play in an adult soccer league, shouldn't I also have an exit test to get cleared? But I'm not a high school, college, or professional athlete. So kind of capturing some of these like outlier populations with maybe a modified version of the exit test and validating something so that it's not just for this really niche focused population. So those are some of the next directions that we like to move.
So I think selfishly, of course, that everyone should use the exit test, but I know that that's not exactly the case. And besides continuing to publish and further validate, what what do you see as next steps for widespread utilization? Because I think maybe at this point, most people should be and are using the VOMs. Most people should be and are using the Buffalo Concussion treadmill or bike test, but not every clinician helping this population to recover is using the exit. So what are we missing?
Yeah, I don't know what we're missing. I think I don't know. I think clinician awareness, like everybody is very concerned about like safety with starting exertion and has really like bought into using Buffalo Concussion for that initial evaluation purpose to determine if there's autonomic dysfunction or not. So kind of sharing that this is not a Buffalo Concussion test for initial evaluation. This is for clearance. It serves a completely different clinical purpose, um, that we need to be using this to inform our return to play process to make sure that these athletes are safe. So I think it's just continuing to educate, continuing to sort of spread the word that this, again, is not an evaluative protocol, that it's a more clearance protocol. And I don't know always in the PT world that we're using a different test for clearance. Like normally we're monitoring our outcome measures throughout our episode of care. So
Mhm.
this idea of this assessment that kind of swoops in at the end at discharge is a little bit different than our normal clinical patterns.
Right.
So I think just like repetition, ongoing education. So like I mentioned, I'm still treating out of the UPMC concussion clinic, but there's a new individual in the exertion coordinator role at UPMC, Sarah Ostap, and she's who one of the other presenters from CSM that I presented with. And so, I mean, they're still traveling, they're still educating, they're still doing courses. So, like, they're doing their sort of work to spread the word of like, there is this test that you can be using to ensure safety with return to play. And then, as you found out about the exit test, as the program graduates fellows, our fellows are traveling all over the country and trying to establish these concussion clinics. We're working with other universities. One of my collaborators on this study, Aaron Sinnott, is now at the University of Miami. So he's sort of doing his work down there. So I think it's just new and it takes time for science to meet practice.
Uh,
So
yeah.
um, just keep pushing and presenting, and we're trying to get these studies published. And as we're working on publications with one, we're starting a different study on the other because we have a pretty good idea of like where we want to go, like expanding it to other populations and stuff. It just, again, it takes a lot of time. I mean, this study we had been working on since 2018, and just like the rest of the research world, COVID put a like 365-day hold on a lot of this. So I mean, we're just continuing to work together and collaborate and share in our own worlds. Aaron Sinnott is an athletic trainer, so he's kind of working in that area. And Sarah Ostap and Yuka and myself we're working in kind of like the PT realm to just spread the word on like, there is this test that you can do. It doesn't have to be, I guess we do a Buffalo concussion test at discharge and like do some lunges, do some dynamic stuff, whatever I think the athlete needs. There are some standardized ways that we can inform the return to play process.
Right, definitely. If anything I've learned from hearing you speak and talking to you today, like we can do way better than just like a walking treadmill test and then a few lunges. And this exit test is definitely evidence of that. So hopefully the podcast is one step towards making it
Yeah, absolutely.
a bit more widespread. Yeah. So I think that concludes what we have for the listeners today. Thank you all for tuning in to APTA Orthopedics podcasts. We hope you found today's episode informative. Remember to subscribe, and until next time, stay ahead in orthopedic physical therapy.